Good afternoon, everybody. I will take more my position of user for this presentation, representing the hospital, being on the client side in a sense, and speaking a bit about what does it mean to connect a large organization, large hospital to an HIE platform. Just 2 words about current situation. We have a federal law, electronic patient record, EPDG, which entered in force in 2020. We have some special characteristic that laws, regulation are federal, but then the implementation is regional. So you have the directive, but then it's up to each region to implement it, all the healthcare aspects, which resulted in several EPR communities, several XDS domains. We have no central, or only very limited central services, like for managing healthcare professional directories. And we have several technical implementations. Basically, for the patients, we have an opt-in strategy. So only those willing to open an electronic patient record do have one. There is a mandatory affiliation for primary care, since 2 years, birth centers, institution for the elderly, it's from this year, and newly established GPs also from beginning of 22. However, be careful that affiliation does not mean that people do access and that people do contribute to the patient record. So that's basically the situation. We have 8 communities, 8 organizations managing electronic, or 7 managing electronic patient record with the link with the patients. The 8th one has only contacts with healthcare professionals. So, but 8 organizations and 3 different implementations, all following the rules defined at the federal level, which is based on HIE profiles. It's, well, it can be seen as simple while it's based on HIE profiles. It requires quite a lot of profiles if you want to cover all the different aspects. And I will come back on that later for the implementation. More now on our hospital. It's a regional cantonal hospital, public hospital, 2,000 beds, more than 12,000 employees. We have specific aspects regarding hospital information system, because we have a hospital information system live since '77. At that time, it was fully home developed. Even the database manager was management system was home developed because there were no product available on the market. It has evolved a lot, of course, since then. It's a fully distributed system since '96. There's no mainframe. The mainframe was switched off in '95. And still, most of the clinical information system is locally developed. So, which means that it's basically fully under our own control. We make it evolving, we develop it, and we also have to do the integration with other software. And we have a dedicated team from which I'm part of for e-health and telemedicine, so all the communication between the hospital and outside. Regarding the electronic patient record, we didn't wait for the federal law because the initial ID in Geneva is from '98. There was the decision by the government, the regional government, we have to implement something, some kind of electronic patient record under the governance of the patient. So it was an HIE. It was already HIE based, it took a few years between the ID and the system was live. It took basically 10 years until we had a cantonal law establishing the electronic patient record, and then implementation, but it was live from 2010 until September 21, when we moved to a national conformed platform, the community I mentioned before. And we had at that time, September 21, 55,000 patients onboarded and 9 million documents in the electronic patient records, with one characteristic: more than 90% were published by the hospital. Less than 10% were coming from other stakeholders, mostly one laboratory, which was publishing the lab results. Deep integration, patient onboarding, automatic publication of documents, a patient opening his electronic patient record, automatically got all his history from the hospital. So more than 20, 30 years of documentation were automatically published. And of course, deep integration into the clinical information system of the HIE. So 21 was the year for moving from the regional platform to the EPR community. 21 only, also the law entered in force mid-20. The first community was in fact operational at the end of 20. And the regional one to which we are connected, CARA, which covers 5 of the 6 French-speaking cantons, was live in end of May 21. And it was the second out of the E8 communities being live. So it was quite delayed, the go live of the different communities. The last one was certified, I think 1 or 2 weeks ago. So more than 2 years later, the official starting date. So moving from one platform to the other, implementing all the national rules raised a certain number of challenges, and that's the main part of my presentation. If you want to connect a large institution and have a deep integration with such a platform, you have a lot of things to prepare and to implement, to design. And simple things like, how do you know that the patient has an electronic patient record? As we have different communities in Switzerland, there's different organizations, there is no notification. The different platforms do not notify all healthcare providers or all organizations that, well, this person has opened his patient record. And all these 8 communities we have, of course, are connected together, which means that if a patient in Geneva has care in Zurich or in Basel, documents from Basel should be made available through the regional community to the patient in Geneva. So it's not only local patients like we had in the regional platform, it's patients from the whole country. Simple things like, when do you publish document? You have some reports that are produced, they are signed by the physician. Do you publish them immediately? Do you delay a little bit? That strategies to be put in place. It's bad if the patient learns that he has a very severe illness before he discussed with his physician. On the other side, if you wait too much time, it's useless to use the electronic patient record as a means to communicate, to share information with the healthcare professionals. So there's a trade-off between the two. Some documents should never be published in the electronic patient record. Example, the pedopsychiatry. It's a relationship between the child and the healthcare professional. But for a child who has access to the electronic patient record, it's the parents. So if you publish such document in the patient record, also it's part of the patient record, but you break the confidentiality between the child and the healthcare professional. There are certain number of things to be careful, and it's not technical things. It's really organizational challenges. We also have an audit procedure. Every community has to be audited, but also the healthcare organizations have to be audited to be sure that they follow the rules, the ordinances, the law regarding the connection to electronic patient record. Then you have technical challenges, and that was already raised in other presentations today. The question of the competencies, having people knowing, in our case, the IHE profiles, all the different aspects. And if you do a full deep integration, it covers a large number of different competencies. You have all what regards to documentation, but you also have patient management, you have healthcare provider directory management, you have security aspects, we have strong authentication, mandatory for connecting to the platform. So there's quite a number of different knowledge to have. And another technical aspects, clearly automatize all what you can automatize. Because if you do everything manually, it's a huge amount of work. Publication of document, for example, for us, it's automatic. When a document is signed in the clinical information system, it is published or it is put in a waiting queue because there is a quarantine, but everything is automatized. Patient matching is automatized also. When the patients come to the hospital, has a visit, has an appointment, there is a check, automatic check if the patient has an electronic patient record. If yes, it's linked and the documentation is published and the link is established. In fact, between the time when the patient comes to the hospital, to the admission desk and sees the physician. So in case he already has the patient record with documents, these documents will be available for the physician at the time of the visit. Challenges regarding healthcare professionals. Complexity of the system is clearly one, and especially the onboarding, the registration, in order to obtain, to be able to access a patient record. The real access then will have to be allowed by the patient. But before, you have to have a login on the platform. To have a login, you have to have a certified EID, two-factor authentication. You have to have a training. You have to register for your EID, then you have to register on the platform to have your login, then to associate your EID with the login. There's a certain number of steps and it's rather complicated. Another general problems, the first three are more related to every healthcare professionals, not especially linked to the ones we have at the hospital. There is a strong interest in retrieving information from the other healthcare professionals. There is far less interest in publishing information for different reasons, one being the workload. Another one is the notion of intellectual property. If I publish what I did, the treatment I prescribed to the patient, I'm giving my intellectual property, I'm giving the way I'm working. And that's something that a certain number of physicians, private physicians, are reluctant. The fact also that many do not have an EHR application, which means that they cannot benefit from a deep integration. So they will have to use the portal, and the portal is not so user-friendly. And there are also things, legal aspects, the responsibility regarding the EPR content. If you have 300 documents and you miss something in the 299th document, what is your responsibility? It was in the patient record, but of course you didn't have 3 hours to look at every document. So that's something that will have to be solved. And for our professionals at the hospital, currently probably 99% of the content of the electronic patient records available is from the hospital. So the chance to have something interesting for them is very, very low. While accessing, they have to enter the second factor for the strong authentication, and then access. For most of the cases, nothing. So it's not easy to motivate them. Patients also raising awareness. If we look at the statistics, 15,000 electronic patient records open for the whole country, but 11,500 only for the Cara community, so 5 cantons. It's about 25% of the population, which has the more than 75% of the electronic patient records. Why? Because in Geneva, we started more than 10 years ago, and we had 55,000 patients enrolled. And we have office in the main hall of the hospital for people who want to open the APR. If they have questions how to use it, how to manage the access rights. And that's one canton now, Vallis, started doing the same, having such box in the whole of the 4 main hospitals of the cantons for incitating patients to register, to open the record and supporting them. And without proactive communication to the patients with the opt-in, it will never work. And software providers, some challenges. Deep integration for sure is a key success factor, but it's complex. You need knowledge, you need trained people to implement that. And the move towards structured information is necessary, but it's currently, I think almost all documents in DPR are PDF documents. There is a will to move towards structured documents for the vaccination, for the medication, laboratories for later, but to be done still. So as a conclusion, the HIE is live. It's running. The 7 communities are connected together, but there's a certain number of concerns that will have to be solved. The question of the amount of documents. Do we publish too much or not? How can we select the things? Questions of responsibility, integration of the mobile devices data, and more related to IHE. What we saw is that it's a strong support for a good implementation, proper implementation. Also to be vendor independent. With the old platform, it was IHE based, but the interfaces were proprietary. So we had to redo everything. One of these 8 communities changed the provider after a few months. But as everything was IHE based, there was no impact for the users. And the fact that you have testing tools, that you have Connect-a-thon, you have Project-a-thon, we have every year Project-a-thon for the EPR infrastructure in Switzerland. We added now, we are working on the e-medication, and we have now also a part for the e-medication in the Project-a-thon. So that's also a strong help for a good implementation. And what is very important to realize is that the EPR, the EPDG, is not the goal. It's one step towards the goal. It's a key step because it's the foundations. But the success will come with additional services like e-medication. We are developing an e-medication service for the moment for the Cara community. Lab results, having an Excel-like table with all lab results. Whatever the lab produced the result. Access to images, access to access for mobile apps. There's a lot of things still to do. So it's one very good step, but it's not the goal. Thank you. If you have any question.